Welcome. Thank you so much for joining us today for Assessing and Promoting Bone Health Across the Lifespan, part of our Value of Diagnostics Within Women's Health series. I'm Katie Schubert. I'm President and CEO of the Society for Women's Health Research. SWHR is the thought leader in promoting research on biological sex differences in disease and improving women's health through science, policy, and education. SWHR's Value of Diagnostics Within Women's Health series highlights the importance of advances in screening and diagnostic technologies and approaches throughout the lifespan, with a focus on how we can improve health outcomes for women, particularly relating to female cancers, reproductive health, and bone health. We are pleased to have two distinguished panelists joining us for today's public forum in recognition of May being Osteoporosis Awareness Month. Dr. Laura Tosi, Director of the Bone Health Program at Children's National, and Dr. Alana Sirota, an ambulatory care physician in the Department of Metabolic Bone Disease at the Hospital for Special Surgery. I'd also like to thank the sponsor of today's event, Roche. As always, we are live tweeting during the event. We invite you to join us and use the hashtag SWHR Talks Diagnostics and SWHR Talks Bone Health on social media. And at this time, I'd like to introduce SWHR's Chief Science Officer, Dr. Irina Ninye, who is moderating today's forum.
Welcome. Thank you, Katie, and welcome everyone. Spanning from simple blood tests to x-rays to invasive procedures, modern diagnostic tests and procedures are an essential part of clinical care, aiding in the detection and monitoring of diseases and informing treatment decisions. Innovations in diagnostics can provide access to valuable information to help women make informed decisions about their healthcare across every stage of their lives. Approximately 54 million Americans have low bone mass, placing them at increased risk for osteoporosis, a condition in which bones become weak and brittle. Risk of bone fracture is higher in women compared to men, in part because women tend to have smaller, thinner bones and due to the influence of the hormone estrogen. Breaking a bone is a serious complication of osteoporosis, and approximately half of all women over age 50 will break a bone because of osteoporosis. As you'll see from our presentations today, there are a number of screening tools available to aid in the early detection and prevention of osteoporosis, which can vastly improve the health and well-being of women if successfully used to avoid fracture. We'll start with our panelists' presentations, and I will now introduce Dr. Laura Tosi, who will share more on addressing bone health in women throughout the lifespan. Thanks for joining us, Dr. Tosi.
Apologies, I couldn't come off mute there. I'm back. Good morning, and it's a great treat to be with you today. I am a pediatric orthopedic surgeon by training and by career. And as my patients and I get older, the importance of educating everyone about bone health across the age span has become particularly important to me. I really have essentially no disclosures. I have tons of volunteer work. My husband keeps hoping I'll get paid for it one day. I do have one research grant from Ultragenics, but that's it. So as a pediatric orthopedic surgeon, I always feel badly that people don't adequately appreciate bone. And I was so tickled by this old Got Milk poster, because it really shows how reliant people are on their bones to hold them up and give them independence. On top of that, the bone serves as a major storage form for calcium in the body. And I'm always stunned by how people don't appreciate calcium. But the fact of the matter is your calcium needs to be perfect all the time for your heart to go lubbed up. It's also pretty magical. It's the only organ that's able to heal without scarring. And we're coming to recognize that it provides significant endocrine function as well. Okay. This slide is old, not exactly accurate, but it allows for a number of important teaching points. First, there is significant sexual dimorphism in bone. What this slide doesn't really show is that most women actually stop forming bigger, better bones by the time they're about 14. Men more 18 to 20. And because they have more time, the men build bigger bones. Men don't go through menopause. So you see the women's peak there takes a decline that the men's doesn't. And then after menopause, they start losing at the same rate. But that means that they can hit the fracture threshold much earlier than the men do. And frankly, I always say the men cheat. They die before they fracture. And we aren't going to focus on fractures today, but let me assure you, that is a huge issue for women because it will take away independence. One of the things I will try to focus on, however, is the width of the line. That isn't there just for decoration. Some women do better than others. And the question, the serious question is, can we help women make a difference there? So the analogy I use when I'm working with my residents is, okay, we're going to the beach and we're going to make a sandcastle. If you make a lousy sandcastle, it's going to wash away in one or two sweeps of the tide, and bone is at risk just the same way. Now, there are many things that go into someone's peak bone mass, and let me just stress over and over again, how much bone mass you have defines your fracture risk. So genetics, nutrition, mechanical, hormones, we'll touch briefly on all of them. Now, some things we say you can't change. Your ethnicity, of course, your genetics, of course, your maturation. The irony is we don't really have all the information we need on sex yet, because as people are choosing gender affirming treatments, we really don't know what's going to happen to their bone. And that's an area of serious research for the future. But in general, as I showed you, your birth sex will significantly influence how much bone you have. Now, what matters? There was a fabulous systemic review done by the National Osteoporosis Foundation in 2016. And I hope you can see my slide. This is what's the value of the evidence. It's a grade A, B, C, D. I briefly want to spend a minute on that. Fat, protein, not so much. Calcium, essential, absolutely essential. And I can't begin to tell you how many patients I have, boys and girls, who come in who never, ever have milk, yogurt, ice cream even. Vitamin D only got a B, but frankly, that's because there was so little research on it. We skimmed down other food patterns, not so much. Sadly, infant nutrition, not. Special issues, certainly oral contraceptives, alcohol, smoking are all issues of concern. But if you're going to have a positive effect, I would argue gym, sports is just as important as English, because you look at this A rating. Are folks getting their impact loading or not? And it's really important for folks to recognize that peak bone mass is really a time-limited offer. You either get it or you don't. And in the 4 peripubertal years, children gain 40% of their peak bone mass, more than they're going to lose in a lifetime. And sex clearly makes a difference here. You see the girls are having their peak height velocity earlier, and many things will influence whether kids make their genetic potential, of which disease, failure to exercise, et cetera, can have a huge impact. How does bone grow? Well, everyone can sort of think of the hollow tube or even a paper towel tube, but bone grows bigger and bigger. It grows and gets thicker to provide bone, particularly in women, and I'll show you that in just a minute, with calcium to give to infants. And then as we age, boy, do we start to lose it. But here, this is fun. Here's the difference in males and females. So if you look at the top where we've got the men, they never get bone as thick as we do because their bone isn't built, of course, for lactation. The irony is, unfortunately, that they hold on to the bone better than we do. And you can see that in the male, the cortical thickness is significantly greater than it is in women, which really adds to the strength and lower fracture rate. In my kids, and I deal with a tremendous number of kids with birth defects and chronic diseases, we see that as we have more and more children with chronic diseases surviving, that bone health has taken on a whole new import in our children. Our children with decreased muscle forces like muscular dystrophy, kids who have malnutrition for a wide variety of reasons end up with worse bone, delayed puberty, inflammatory disease, growth hormone deficiency, increased parathyroid hormone, and all the different medications that those kiddos are on, steroids being for cancer treatment, for rheumatologic treatment, all are poison to the bone, and we're trying to help kids overwhelm that. In our young women, anorexia is a biggie. And the harsh reality is, so here we have sort of a different take on that peak bone mass slide that I showed you earlier. The folks who reach their full genetic potential can do pretty well, lose maybe not so much in menopause, not really ever develop a high fracture risk. Our girls with anorexia never meet their genetic potential unless one's very lucky and turns them around really early. And it is painful to see young women with vertebral compression fractures because they just don't have the bone density to do what they want to do. And we have limited ability to help them. So one of the interesting questions, which frankly is mostly philosophic at the moment, is does peak bone mass really matter? We know it does in kids. And we know that with every standard deviation, someone falls below average, they have an 89% increase in fracture risk. That's a lot. Does it matter for a little old white lady like me? Not so sure yet. Personally, I strongly believe it does. And that low bone strength, when one becomes mature, will likely be associated with fracture risk in later life. But the fact of the matter is the data is not there and the jury is still out. And of course, life happens. If someone develops cancer, has to go through chemotherapy, someone has a bad accident, many things can affect bone density as people hit their senior years. But based on everything we see and know, I personally believe peak bone mass matters whether you're a boy or for a girl. And here's really the important thing. This is old data and it's absolutely current. We women fracture more, we fracture earlier, and we are particularly vulnerable for hip and vertebral fractures. And as an orthopedic surgeon, I'm proud of the surgery we can do to get women back up, but women lose a huge amount of their independence, their ability to do their activities of daily living, etc. And vertebral compression fractures, oh my, that hurts and it takes a long time to recover from. So protecting women and men from these terrible things is hugely important. So Sir William Dent said senile osteoporosis is a pediatric disorder. I believe it. And so getting back to my sandcastle analogy, my goal is to have all my patients build the biggest possible, strongest possible sandcastle that they can, so that when that tide comes in, they're still standing proud and independent. And that's the term I use for my kids all the time. I want you to be independent. So diamonds aren't a girl's best friend, I would argue. Bones are. And I hope you'll share that with everyone you know. So in celebration of osteoporosis, here we go. Thank you for your attention.
Thank you, Dr. Tosi, for that introduction on bone health. And we invite in those who are tuned in, you can submit questions at any time using the Q&A box at the bottom of your screen, and we'll try to address as many as we can during the panel discussion portion at the end of this event. Next, we will have Dr. Alana Sirota discuss bone density screening guidelines and diagnostic tests that we can use to understand where our bone health is.
Thank you so much. Hopefully you can see everything. Dr. Tosi, that was wonderful. I wish that I'd had my daughters watch it. I have teenage girls. So we're going to talk about catching a silent thief, because osteoporosis is clinically silent until you break something, and we want to prevent that first fracture. So how do we catch this silent thief? The gold standard for measurement of bone mineral density is the DEXA scan. Sometimes you'll see it written as DEXA, but the correct format is DXA. This is used to diagnose osteoporosis and monitor skeletal status. We measure it at the spine, the proximal femur, which is your total hip and femoral neck. Many people think it's their neck. It's actually the skinny part of your hip bone, as well as the radius, the wrist. Global guidelines and recommendations are based on these measurements. So the WHO gives us the diagnostic classifications, which I'll review in a moment. Regional guidelines tell us when to measure, to screen patients. BHOF and other regional organizations make treatment recommendations based on these measurements. And the International Society for Clinical Densitometry keeps our machines precise and honest, and also guides us about when and how to use. So the DEXA scan is oftentimes done in the radiology department, but does not, you're not exposed to a great deal of radiation when you have it done. Basically, 2 X-ray beams are used to distinguish between bone and soft tissue. And the radiation exposure is, you could get 30 bone density scans equal the radiation from 1 flight to LA and back to New York. So that often reassures my patients. So whom do we test? What are the indications for bone mineral density testing? So the U.S. Preventative Services Task Force, the update is in progress, but stay tuned. Bone Health and Osteoporosis Foundation, formerly the NOF, National Osteoporosis Foundation, recommends we screen every woman 65 years of age and older, men 70 years of age and older, but younger postmenopausal women and women in the menopause transition, and men aged 50 to 69 who have clinical risk factors for fracture. We pay attention to adults who've had a fracture at age 50 or older, as well as adults with a condition, commonly rheumatoid arthritis, but there's a laundry list of conditions that can lead to low bone mass, or an adult taking a medication such as glucocorticoids, so steroids like prednisone, aromatase inhibitors, which we use after breast cancer, and androgen deprivation therapy, which we use after prostate cancer, that can be associated with low bone mass, low bone density. The ISCD guidelines are very much in line, but they're a bit more refined and detailed. There's attention to that low body weight as a risk factor, as well as making the point that anyone who is being considered for or monitored on treatment will need regular scans. So how do you prepare yourself or your patients for bone density to get the most accurate result? You want to make sure that you stick with the same facility and machine year after year. Even if we move our machine from one room to another, we have to cross-calibrate. You want to make sure that you hold calcium supplements for 24 hours prior. Some institutions say 48. You want to make sure that the patient has not had, or you have not had, CT contrast or barium exposure within the last 14 days. metal objects and clothing are removed. And this is a big one, and this is, for everybody. Strontium is a very hot supplement right now, but it has a higher molecular weight than calcium, so it makes bones look brighter and can falsely elevate the bone mineral density by 10%. This effect can last for years after strontium is discontinued, so I always have my patients bring in a bag of their stuff. I read the back of what they're taking. If there's strontium, it goes in the garbage. So this is the WHO diagnostic criteria for the bone density results in postmenopausal women and men over 50. So if your T-score, which is looking at you compared to people at your age at their peak bone mass, it's the only time you should be compared to anyone in their 20s or 30s. If that T-score is above -1, then you have normal bone density. If you have a T-score between -1 and -2.5, that is what we now call low bone density. The term osteopenia is sort of falling out of favor. Osteoporosis is a T-score of -2.5 or less, and we consider it severe or established osteoporosis when there's that same T-score with a history of fragility fracture. Now, beyond T-scores, bone density tells us about your square footage, but now we have a way to look at your retaining walls. So the trabecular bone score is acquired at the same time as you have a bone density scan. It relates to the bone microarchitecture, the honeycomb bone in your spine. How well organized is this bone? Osteoarthritis, which of course at HSS we see a great deal of, has little effect on trabecular bone score. It can make your bone density look artificially high. It is an independent fracture predictor, so it enhances our ability to predict who will fracture. It can be added to the FRAX, which I will explain in a moment. And as well, our medications that we use for osteoporosis differ in the extent that they influence the TBS. So it doesn't just help us make the diagnosis, it also helps us choose how we're going to treat. So as I mentioned, bone density and TBS are better together. We have these three categories of a bone density diagnosis: normal, low bone mass, or osteoporosis. And so too with the trabecular bone score, we have normal, partially degraded, or degraded. And so all of a sudden, instead of having 3 risk categories, we have 9. So the FRAX is a fracture risk assessment tool that I had mentioned before. We use this to estimate fracture risk in untreated women and men between 40 and 90. And we only use it for those who are in the low bone density, what we used to call osteopenic range, simply because of the area under the bell curve. Most of the people who fracture are in this range, and some are at low risk and some are at high risk. So we use this FRAX to make the determination. It is also possible to calculate the FRAX without a T-score, so without having had a bone density test at all, for those who do not have access or who have other barriers to care. And when you input your clinical information into the FRAX, if the probability of a major osteoporotic fracture is more than 20% in the next 10 years, or the probability of a hip fracture is more than 3% in the next 10 years, the risk-benefit ratio favors treatment. And this is what the FRAX looks like. And you have a section that you can move to and then add the TBS, which further refines the risk calculation. Beyond just T-scores and bone density, you are also able at the time of a DEXA to do a vertebral fracture assessment. This is the silent crime of the silent thief, because 2/3 of vertebral fractures are clinically silent. They are the most common fracture that we see. And we recommend that this is added to the DEXA for women 70 and older, men 80 and older. We recommend it if there's height loss. If you're, the difference between what it says on your driver's license and what your doctor measures you at is more than 1.5 inches, or if your doctor has been prospectively measuring you, even a little less than 1 inch, warrants attention. And these are vertebral fractures are particularly common in patients on glucocorticoids. So that's another thing that would prompt you to order this vertebral fracture assessment. We can also look at both femurs to screen for atypical femur fractures, which are very rare complications of long-term anti-resorptive agents for osteoporosis. 70% of the time, patients report a prodromal thigh pain. They're oftentimes bilateral. So patients of ours who have been on long-term bisphosphonates or denosumab, which is Prolia, especially if on steroids. This is another a study that can be added to the DEXA, so it's very efficient for the patient, and you get all the data that you need. So we talked about how we diagnose osteoporosis by DEXA, by your T-scores. We talked about the FRAX and the probabilities that lead to treatment, but we haven't talked about the most important thing, which is fractures. This is our whole raison d'etre, to keep you out of the emergency room and to keep you out, sometimes even the operating room with repair of those fractures. So fractures from a low trauma, fall from a standing height or less. If you have a hip fracture, that is osteoporosis by definition. It really doesn't matter what your bone density shows. If you have a symptomatic, a clinical vertebral fracture, a proximal humerus fracture, or a pelvic fracture and low bone density, we would consider that meeting the clinical diagnosis of osteoporosis. Morphometric vertebral fractures, meaning those vertebral fractures you find incidentally, you have to listen to the story. Is it a 50-year-old man in front of you who had a diving accident when he was 20 and had an episode of back pain? Probably not osteoporosis. If it's a 63-year-old woman who has low bone density and had a fall down the stairs, that is likely an osteoporotic fracture. With regard to the distal forearm wrist fractures, the mechanism of injury really makes the determination. So trip and fall in your bathroom, osteoporosis. Slammed into a tree rollerblading in Central Park, which I've seen, probably not osteoporosis. So DEXA is wonderful and helpful, but it does have limitations. It tells us about bone density, bone size. It's a composite measure of cortical and trabecular bone, and the results correlate with fracture in clinical studies. But what it doesn't tell us about the quality of the bone, the strength of the bone, the mineralization of the bone, or the collagen quality. And when we do studies with cadavers, the bone mineral density doesn't tell the whole story. It's 60 to 80% of the bone strength. And so, because this is the Society for Women's Health Research, this is a research tool now, but may not be in the future, high resolution peripheral quantitative computed tomography, so HRPQCT, which is a virtual bone biopsy that gives us this unbelievable detail of bone. It tells us about the size, the volumetric bone mineral density and microarchitecture. We can estimate strength. So stay tuned. We finally got one of these at HSS and we're very excited about it. Once the DEXA, you make the DEXA or clinical diagnosis of osteoporosis, we always have to look at the patient and evaluate for secondary and contributing causes. And that is done through both blood and urine studies. In all patients, you want to get a sense that there is nothing correctable, like a vitamin D deficiency, or treatable, like primary hyperparathyroidism, which is treated with surgery. Prior to starting treatment with bone-specific agents, sometimes they will even work at cross purposes. And then in selected patients, and this is certainly not an exhaustive list, there are more refined tests that may be prompted by family history, patient presentation, or your physical examination. Now, despite all of this, the availability, the osteoporosis remains underdiagnosed and undertreated. Only 1/3, as I mentioned, of vertebral fractures come to clinical attention, and 80% of people who have at least one osteoporotic fracture are neither identified nor treated for osteoporosis. This is even less, even more of an issue in non-white women. They're less likely to be screened, less likely to be prescribed pharmacotherapy, and less likely to receive treatment post-fracture. I realize this is the Society for Women's Health, but we all have men in our lives, and men are also underscreened for osteoporosis, undertreated when they have fractures, and tend to have a higher mortality risk after hip fracture. So we have the tools, we just have to use them. Thank you very much.
Thank you, Dr. Sirota. I invite you both to turn on your cameras. And again, for those that are tuning in, you can submit questions using the Q&A box at the bottom of your screen. We'll try to address as many individual questions or common themes as we can during this discussion. And from some of the questions we've gotten so far, we have DEXA and there's some screening opportunities and some other tests that can be used. And Dr. Tosi, you also talked about the peak bone mass. The likelihood of the those that are tuning in being over 15 is pretty probable. So what can someone do as an adult to either build back bone mass or try to at least strengthen their bones, considering they might have missed that window and they don't know where they are? Oh, you're muted, Dr.
Yep.
Tosi. Yeah.
And I certainly want Dr. Sirota to chime in here, but I think maintaining bone mass is really important. So making sure one has adequate calcium and vitamin D in one's diet, that one is actually having protein. It's interesting. Americans don't really know how to do vegan diets. And so many of our vegan patients are protein deficient, which influences their bone mass as well. Exercise is really important. And one of the ironies is swimmers often have lousy bone density. Boy, are they getting those muscles, but they're not impact loading. And I'm always trying to get all of my patients and their parents out there taking brisk walks so that they are impact loading their bone. The issue of building bone naturally is a toughie. And there is some evidence that weightlifting, weight exercises can help a teeny weeny little bit, but it's not a lot. The medications that we have to help us deal with osteoporosis come in all different varieties, and there are bone building medications, but clearly we only prescribe those in very serious circumstances. I will tell you that one of the fun things is balance counts. No matter how good or bad your bone density is, you don't want to fall down. And I do think that Tai Chi really is great. I confess I only lasted 3 lessons because I died of boredom. But I try to do other things like Zumba and whatnot to work on my balance. And to everyone on the call who has low bone density, look for those ways to work on your balance as well as your strength.
I so appreciate your comment about vegan diets, because we see that all the time. You know, we need the 3 C's. We need calcium, cholecalciferol, which is vitamin D, and calories. And those calories need to be quality calories. The delta between exercisers and non-exercisers, Dr. Tosi's couch potatoes and exercisers, there's a big difference in their bone density. As we age, especially post-menopause, it doesn't make that much difference. It's important to exercise because it's good for your health. It's good for your balance. It slows the rate of loss, but you're not going to, treat osteoporosis by exercising. It is necessary, but not sufficient. Just having patients, I live in New York City, everybody's walking every day. You do the farmer's carry, you're holding weights every day. So it doesn't have to be jumping or bouncing, although there is interesting data in children with the bouncing and the jumping, but you need to be sort of using your weight against gravity every day. And I have my patients every day when they're brushing their teeth, they tighten up that core, they stand on one leg, and then they switch. Just that is just to make sure that you're integrating that balance into your life every day. That's the recommendations from Too Fit to Fall or Fracture. Then I have them challenge themselves, do a tandem walk like you're getting a sobriety test. That the longer you do it and the more stable it is, and do it in different footwear. Do it barefoot, do it on your carpet, do it on your wood floor. And you see that when patients, sometimes my patients will say, oh, I was on a long vacation and I didn't practice, and they'll notice a difference, or if they've had surgery, what have you. So the exercise recommendations are, so in addition to daily balance, that you are doing some kind of weight or resistance training at least 2 days a week. And that can be weighed against, you can do a plank, that can be using bands, that can be using, actual sort of pump and iron, Arnold Schwarzenegger's type stuff. We also recommend it's 150 minutes of aerobic exercise so that you're getting your heart rate up and you're breathing hard enough that you could talk, but you can't sing. And, I tell my patients, I don't care if that's, 15 times you do 10 minutes of jumping jacks, just get it in there. Lord knows I could meet that goal myself. The other thing that you want to remember is that we all live in these very crouched forward worlds. And you want to just be mindful of your posture every so often during the day, sort of pretend like there's a string at the top of your head. Think of your clavicles as wings and you want to spread them. So positioning, balance, and get sweaty.
Get sweaty. We're talking about maintaining bone mass and healthy bones, and there's the different supplements and things that everyone can take. But if you have osteoporosis, you already have a low bone density because it's basically something that you already have, and then DEXA shows you that you have it. So you can have osteoporosis before you get a DEXA scan and not be aware and be moving about life without, being cautious enough. But there's two questions. One is that maybe we'll do that later, fear, fragility, like you have it. But with treating osteoporosis, what is the focus of the treatments? What are those options? And we don't necessarily want to go down, take this, this, and this, but what actually happens when you're treating for osteoporosis? What should someone be looking forward to as far as the outcomes for treatments?
Oh my, that's a broad.
Well, I guess ultimately, because you said you can't build it back. So what are the
let's speak to that, because my greatest experience, I'm a pediatric orthopod. I run a bone health program and I treat children who typically are disabled and have very low bone densities. And in kids, we can increase the bone density. And we can really change the natural history of disease. And this turns out to be very important, either with kids with congenital diseases, such as brittle bone disease, osteogenesis imperfecta, or kids on steroids, which isn't just the arthritis kids, our muscular dystrophy kids. We can really change their future and their quality of life, because if you are growing, we can help that get better, or at least not get worse. And our children on chronic steroids will have many, many vertebral compression fractures. I think as we get into 20, 30, 40, 50, I think it's important for women to look at what they're on. Women may have thyroid disease, they may be on steroids for a different rheumatologic problem. And particularly if they're on steroids, they have to really get with a bone health specialist and say, I need to take bone poison every day. What do I do to help protect myself? Or I had to have my ovaries removed for some reason, and I don't have estrogen anymore. What do I do? And so I think it's important not just to focus on the postmenopausal woman, because there are a lot of preventative things that must go on in that sort of midlife period. The interesting things is that some of the newer drugs for osteoporosis, and I'll go right back to Dr. Rhoda in a minute, but are very exciting because they can improve the bone density. But they're very expensive. It's hard to get insurance to approve them. And you don't want to have to need to be independently wealthy to take these drugs. The traditional drugs, which are particularly the bisphosphonates, and people have heard the term Fosamax and alendronate, that sort of thing, are good holders of bone, but they don't really make much new bone. But they are typically our first line of defense because they've been out there a long time. They have a reasonable cost, and they are highly correlated with fracture risk reduction. Now let me turn you over to somebody who can speak to that better.
So, I think actually my focus is actually the younger patients, right? So for the average person, we talk about this postmenopausal stuff, but certainly if there's a secondary or contributing cause of osteoporosis, bone loss in that sort of 20 to 50 year age range, there are a lot of things that we can change. Just treating an inflammatory disorder appropriately and lowering the inflammation also decreases the insult to the bone. I can't tell you how many times I've picked up celiac disease and the first sign of celiac was a fracture. No GI symptoms at all, but patients just had a chronic malabsorption. Vitamin D levels of 13, that, when you do the bone density at the next time when the D is replete, you've actually remineralized your bone. All of these things are, something to pay attention to. And certainly for many years, hormone therapy, the baby was thrown out with the bathwater. Data from women in their 60s was applied to women in their 30s and with premature menopause incorrectly. We use estrogen to replace estrogen in patients who should have estrogen and who do not. For up until the time of natural menopause, sometimes beyond. We now have a different pathway for treatment. The AACE 2020 guidelines really refined sort of high fracture risk, the just sort of plain garden variety osteoporosis. You start with any one of the drugs that we have, most often and most economically the bisphosphonates. But then for those who are at very high fracture risk, really low T-scores, like below -3, recent fracture, because in imminent fracture risk, if one fracture predicts another more often within a short time frame, frailty, falling, very high FRAX scores, like over 30 and 4.5%. Those patients we start with, it's recommended that we start with, if affordable, the bone growing agents, so that we are we're not just painting, we're renovating, we're adding an addition. And that because number one, they work best when you start with them first. And number two, even in head-to-head trials compared to the bisphosphonates, the fracture protection is far superior. So that's when we go for the big guns. And there are 2 plus daily injectables. One has a biosimilar. There is a monthly injectable that we're starting to use a lot more, which has had excellent results. And then we follow it up with those bone maintainers. But that sort of sequential therapy is kind of where the state of the art is now.
Thank you so much. We want to wrap up because we're saying we're at the end of our time, but we often have a lot of patients, healthcare providers. We also have some researchers, policy professionals that tune in to our webinars like this. And so what is one takeaway briefly that you would recommend to viewers to help them support screening or treatment of bone health?
Just think about it. Bones get forgotten. It's airway, breathing, circulation, and bones are way down on the list. And just think about it. We want to make sure that it's not just quantity of life, and it is quantity of life, but it's quality of life. People think, oh, you just break a bone and it's fine. It's not true. You have a spine fracture, you have a hip fracture, even a wrist fracture can be life-changing, life-altering, and certainly in the case of hip fractures, life-ending. So just think about bones.
I couldn't agree more. I think that we all want to be independent, and helping the whole family be independent is really important. That it really has to be viewed as something that spans one's entire life. And we can't just say, oh, well, he won't drink milk, she won't drink milk. You have to say, this is going to have huge implications for later on. How do we as a family change, if they won't drink milk, our dietary patterns so that we are getting calcium other ways? And by the way, that's hard to do. I have these girls who say, I'm going to do it all with broccoli. And I say, great, about 40 cups of broccoli 3 times a day. Let's get that ready right now. And, you can't do it with broccoli. Collard greens are better, but you can't do it with collard greens either. And so helping folks understand that while we evolved to hold on to salt and hold on to water, our bodies don't hold on to calcium. We're losing it in our tears, in our spit, in our pee, in our poop, in our sweat, all day, every day. And it's got to be replaced, or the bone will be robbed, and there will be a terrible price to pay. And I don't know about you, but I'm an independent cuss, and I want to stay that way.
And one last brief clarification, which doctor can someone go to if they wanted to get a DEXA or find out about bone health?
Well, you know what? All politics are local. In general, it can be primary care in some circumstances, rheumatology, endocrinology, OBGYN.
Okay.
And really, this is where women have to stick together and find out who in their hometown cares about this subject and is really willing to help other women.
That's
You
great.
agree? Yeah.
And much less often an orthopedic surgeon like Dr. Tosi, who really owns the bone. There are not many, but we love them.
Yes, thank you so much. And finding that support. We thank you. You guys have been an amazing panel, bringing your time and your insight to this program. And we also want to say thank you to Roche for their support of this public forum and SWHR's Value of Diagnostics within Women's Health series. We are continuing the conversation as hashtag SWHR Talks Bone Health during National Osteoporosis Awareness Month, as we partner with the Bone Health and Osteoporosis Foundation, as well as the American Society for Bone and Mineral Research, for a national webinar and congressional briefing entitled Steps to Strengthen America's Seniors, How Preventing Osteoporosis Helps America's Health System. Together, we aim to drive policy changes to improve access to appropriate bone health screening, including DEXA screenings that we talked about today, and treatment to ensure better health outcomes for women of all ages and backgrounds. So we are looking forward to highlighting more areas of women's health that benefit from innovations in screening and diagnostics. Our next event will be on June 8th, and will focus on the value of diagnostic tools in fertility care in recognition of Infertility Awareness Month. We invite you to connect with us on social media and visit our website, www.swhr.org, to register for future events, download women's health resources, and sign up for our newsletter. We will be sending out an email with a recording of today's webinar to all registrants, as well as posting a recording of this event on the event's webpage for future viewing. So please be on the lookout for that and feel free to share widely with others. As we continue this conversation, hashtag SWHR Talks Diagnostics and hashtag SWHR Talks Bone Health. Thank you for joining us.